So it's always a pleasure to come back to the West Coast and to Canada in particular, where I have a lot of friends. As Martin told you, I've been at NYU for 28 years, and during that time, done a lot of different things. I would consider myself sort of a urologic jack of all trades, sort of in the prostate cancer field. I've dabbled in a lot of different things. Today, I was really going to talk to you primarily about our experience with MRI-targeted biopsy. Whenever I'm labeled as a visiting professor, what I like to do is talk a little bit about how a simple clinical question can lead to a career of inquiry. And I think that's important for people in training, that you don't need a very elegant research question to start out. And I wanted to talk you through how our MRI-targeted inquiry started and what we accomplished, and how it's been very satisfying in that the things we've learned have really informed our practice. No real disclosures related to this. So going back to how we started in the imaging world, as Martin told you, I started in molecular biology. I was also very interested in biomarkers and androgen regulation. That led somehow into imaging around the early 2000s. And at that time, we were in a different era of urology. We'd come through the PSA screening era. There were a lot of concerns about overscreening, overtreatment. The pivot trial showed that there wasn't much benefit for treatment, and PSA was being very heavily criticized, and recommendations were coming out against it. We sort of asked the question differently, though, and said maybe it's not really the biomarker that's the problem. Maybe it's the data we're deriving from the biomarker, and maybe it's not the response to the biomarker, but in fact the biopsy itself and how we're doing it. We're basically randomly poking the prostate to see what's there, and no real correlation with the biomarker specifically. The limitations of traditional biopsy were fundamentally three: that you could find clinically insignificant cancers by chance, you could find important cancers but incorrectly risk stratify them through poor sampling, and that you may miss cancers altogether. And our thought was that maybe that random sampling assessment was really diluting the signal of prostate cancer detection in the screening population, and thereby diluting the impact of treatment. Around the same time, the AUA asked me to chair a white paper on optimizing prostate biopsy. And we defined prostate biopsy and its optimization as detecting potentially lethal cancer, avoiding overdetection, generating clinically useful data, and somehow maintaining cost effectiveness, because at that time in the United States, every core had an individual charge. The pathologist would charge for each core separately, and Medicare was concerned that the cost escalation was unsustainable, which it probably was. Around the same time, I got a big donor-directed gift to focus on imaging and ask questions. I had a donor come to me with a card in his wallet with all his PSAs and say, this is bullshit. You guys tell us it goes up and down, but what does it really mean? Can you do better? And so we thought, well, this is a good opportunity for us to establish a program, and we did. We brought in collaborators from computer science, software design. We brought in imaging scientists to help us with coil design, molecular biologists, and I had a group of clinicians, trainees, and colleagues who sat down and focused in the area. We defined our goals fundamentally as to refine and optimize our imaging, and then to develop methods for MRI-targeted biopsy, which we could use essentially as a clinical laboratory to validate the imaging findings and further refine them. And from that came improved biopsy outcomes, risk stratification, better surveillance, better data to counsel patients, and of course, the new paradigm of focal therapy. So from the initial question of can we see the cancer and what can we learn from cancers we see, came a lot of clinical offshoots. The first question we asked was really, what does tumor detection on MRI mean? And it's still a question that I think we're asking on a regular basis and haven't fully understood. We know that when you see tumor on an MRI, it predicts a higher risk of recurrence. It predicts greater progression on surveillance. And we know that the quantitative metrics we apply to the imaging, the ADC, the apparent diffusion coefficient, the suspicion score, they're predictors of high-grade disease. But unfortunately, you can't segregate disease purely with the MRI, at least by conventional parameters. The confidence intervals between high grade and low grade disease are widely overlapping, although there is a strong correlation. Early on, my colleague Andy Rosenkrantz and I did a study where we said, what is the difference between tumors we clearly see and those we don't? And so this was a patient who had a clear evidence of a tumor on the left side in the peripheral zone where the arrows are, and then tumor on the right side, similar size, but completely undetected. What we learned that there were a lot of morphologic characteristics that predicted imaging visibility, including Gleason score, but also, interestingly, the ratio of epithelium to stroma, the vascularity of the tumor, the density, the presence of desmoplastic stroma. And of course, we liked the idea that maybe all of these things were biologic predictors. And I'll talk about that in a few minutes. There are now a growing number of supportive studies that suggest that genetically these are different cancers as well. Now, one of the first things we had to do was say, how are we going to query areas that are MRI targeted? And so my colleague Jim Weisach, who's now been on our faculty for a decade almost, was our fellow. And at that time, his master's thesis was a study called the Profuse study, where we basically looked at a fusion biopsy versus a cognitive targeting. This was when fusion applications first came out. And what we showed, although it didn't quite achieve significance, was that regardless of this slide, it didn't show up that well, but at the bottom you see biopsy indications, biopsy naive, previous negative biopsy, or active surveillance. Regardless of the clinical indication, if we used fusion, we tended to find more cancer and more clinically significant cancer. And in particular, we felt that fusion was very good at finding small targets, so you could sample small targets a little bit better, and tumors that were located in the anterior prostate. And remember, everything was transrectal in those days. So anterior localization was difficult using a cognitive technique. So in 2012, we made the decision at NYU that going forward, every patient who came to us at our institution with elevated PSA would be given an pre-biopsy MRI. They would undergo an MRI-targeted biopsy. And at that time, it was primarily through transrectal approach. We've, over the years, assimilated more and more transperineal. Early observations are very consistent with what we see today. You don't find more cancer using this approach, but you segregate the cancer better. So it's a better risk stratification. We find more high-grade disease and less indolent disease, and thereby potentially select men a little bit better. This table shows you this. Initially, we used a Likert suspicion score. Now we use PIRADS, but the correlation of the suspicion score with the biopsy outcome is quite good. If you have a high suspicion score, most likely you have red or concerning disease. If you have a low suspicion score, most likely you have no disease or low-grade disease. And of course, the Achilles heel is that indeterminate yellow area in the PIRAD 3 and 4 patients that we see. One of the factors that predicts the likelihood of significant cancer is, of course, the indication. We see different performance characteristics for MRI in people who've had no prior biopsy, prior negative, or prior cancer. And that relates probably to some extent to prevalence of disease. But if you have no prior cancer, your odds of having clinically significant cancer on MRI targeted sampling is going to be greater, for example, for a PIRAD 3 than somebody who's been sampled before. That cuts to a really important concept for the trainees, that any diagnostic test, whether it's a biomarker, whether it's PSA, its performance really varies with the prevalence of the disease in the test population. The other way of saying that is that the pretest probability influences the outcome of the diagnostic testing. So the higher the disease prevalence, the better the positive predictive value of a test, but the negative predictive value starts to suffer. And we see that with MRI in prostate, a screening population, very low positive predictive value for equivocal findings, but high negative predictive value. And if you shift all the way to the surveillance population, there's a lot of literature that shows us reclassification occurs just as much in a systematic sample as it does in a targeted sample. And that's probably the underlying reason for that. So the previous negative biopsy population, the low prevalence, was really the low-hanging fruit initially when we started the work. And we realized that if we used MRI-targeted sampling alone, we really, in our experience, missed no clinically significant cancers by avoiding a systematic sample. And this was a place that we immediately felt that if we did miss cancers, they were low risk. So applying MRI was very wise. And we were talking earlier about the SAR, the Society of Abdominal Radiology's Prostate Cancer Disease Focus Panel, which we established, I think, around 2015 as a collaboration of the AUA and the Society of Abdominal Radiology. And our first white paper was really a joint statement saying that in this population, previous negative biopsy, increased suspicion, this is a place you should use MRI if it's available, and that you could rely on it, and perhaps not biopsy patients if their imaging was unremarkable or low suspicion. The biopsy naive population has been more problematic. And this is a way that we tend to present the data. It's a 4x4 table with systematic biopsy outcome on the left, targeted biopsy outcome on the top, between it all taken in the same patient, and again, color coded for simplicity. But what you can see in the red lettering is that, again, we find more clinically significant cancer and less indolent cancer when we use the MRI targeted sample at the bottom. The red is the concerning Achilles heel, whereas the green is what we want to see. The green is patients who have no cancer on systematic or low grade, but are found to have high grade on MRI. Those are the missed cancers that we're picking up. But of course, there are a small number of cancers that MRI targeting seems to miss as well. And this has been a major focus of the North American community in interpreting MRI outcomes, and I'll come to that. So I want to quickly take you through 4 studies that I think every urologist should understand in interpreting MRI and the pre-biopsy setting. The first is the PROMISE study. The PROMISE study was published in 2017 out of the University College of London, and it was basically a study in which men with elevated PSA underwent an MRI. They had a 12-core biopsy, and then as a reference gold standard, they underwent a transperineal template biopsy additionally to compare. So that was their gold standard, and they compared the outcomes of the MRI and the truss biopsy to the template. Important to note in this study is they defined clinically significant cancer in a way that most of us would not. Gleason 4+3 or higher, or greater than 6 millimeters of cancer core length. This is the MRI outcome. 576 men had the MRI. It predicted clinically significant cancer in about 80% of those men, about 65% of those men, which is consistent. If you do MRIs on elevated PSA, about 2/3 of men have abnormalities. Of those, 51 were deemed to be true positives, and 11% were deemed to be false negatives. So the sensitivity for MRI was 93% for detecting clinically significant disease that was identified on the template biopsy. Important to note, they didn't use MRI targeted sampling. So still possible that you miss things, and that might relate to some extent to the true positive rate. Of course, truss biopsy doesn't perform as well. It has a low sensitivity and a high specificity, as one would expect. So they concluded, MRI is superior to truss biopsy, but the criticism of the study really came in the missed clinically significant cancers. And depending on how you define clinical significance, MRI had what a frequently quoted number, a 24% missed cancer rate among men who were assessed by MRI prior to the biopsy. I won't say a lot about that, except that it's not a perfect study. There's been a couple, I just reviewed a PhD thesis from UCL, and there's been a lot of rehash of this data. Some of the imaging quality was poor. Some of the interpretation, if you go back and look again, maybe it was done wrong. But there's no doubt that MRI doesn't detect every cancer.
Can I just ask you a question about that? Is that, I mean, it's really all about percent of pattern 4. That's what we want to characterize. But the greater than 6 millimeter core length included just pattern 3 disease. Is that right?
It did, yeah.
So if you excluded those, would that, how much did that improve the MRI negative predictive problem?
I don't know that. It's a good question. I don't think I saw that raw data in this thesis rehash, but you're right that the core length part, I think most of us have gotten away from the idea of using cancer volume as a risk stratification. If you have somebody with 6 cores of Gleason 6, we would still consider that patient low risk in my camp. So you're absolutely right.
So I have a question on that front, and sorry for my ignorance on this. Are there data that look at, because I've always wondered, the people who are missed cancers or missed clinically significant cancers, they don't just go back off into the community. They're presumably having active surveillance or PSA screening. Are there data on how many of those patients actually escape, or are you getting to that later?
I don't have that specifically here, but there's a lot of data on that and a lot of criticism of the MRI approach. Andrew Vickers talks about that. The screening studies have shown that people who are benign on a standard biopsy in screening round 1, they're at a very low rate of prostate cancer mortality. That may be age dependent, right? If you're screened at 55, as opposed to being screened at age 70. There was just a paper out in European Urology that talked about age at time of screening relative to risk of mortality as well. But you're right that the rate of missed cancer detection leading to mortality is relatively low. So the precision study was then the next study that we used to better assess this. This was a study we designed actually at NYU, but was carried out at UCL by the UCL group as a global study. And basically, it was a randomized comparison of trust biopsy and pre-biopsy MRI. The key elements of the study, the men in the MRI arm didn't get systematic biopsy. There was no biopsy for PIRED 1 and 2, and it was designed to demonstrate non-inferiority. So this was the randomization, 500 men. In the prostate MRI, again, about a third had low suspicion MRIs and didn't get biopsied. And among the ones who did get biopsy, there was about a 40% clinically significant cancer detection rate using a definition cutoff of 3+4 or higher. The trust biopsy, the rate of cancer detection clinically significant was 28%. So 3 things learned. You avoid biopsy in about a third. You find more clinically significant cancer, less indolent cancer. So it was not just non-inferior, but it was superior. The aftermath of precision was somewhat disparate across the Atlantic. In Europe, precision was enough to fuel a lot of the agencies there to recommend it within guidelines. There were even some third-party payers there, regional healthcare systems that started to require pre-biopsy MRI. But in the US, it was a criticized study because of the concern about cancers missed in the systematic sample in the men who weren't biopsied. And in the US, even to this day, I think pre-biopsy MRI has been largely rejected as a risk stratification tool. It's used by everybody for biopsy. I would say that's now a community standard to do fusion biopsies. But people are very reluctant, although less and less, to avoid biopsy based on the MRI. I would make the assertion to you, though, that that's not sustainable from a cost perspective. It's just escalating detection. And remember, I told you our goal initially was to be able to selectively biopsy men, reduce the number of unnecessary biopsies we do. So for MRI to be cost effective, you have to use it as a risk stratification tool in addition to a biopsy guidance tool.
How much is that driven by the defensive medicine and the medical legal?
I think a lot of it is, Martin. You're right. You know, people are worried about missing cancers, and until these things are put into a guideline, your American urologists feel, unprotected, right? So as they emerge in guidelines, I think there'll be more adoption. I do know in the New York area, maybe a lot because of the influence of the academic centers, community urologists, even primary care physicians now risk stratify using MRI in many cases. So the next study is the MRI first. Now, one thing that Precision showed that most of us have not seen is that you find more clinically significant cancer with a systematic biopsy. With an MRI targeted than a systematic, dramatically more. It's usually incrementally more, and this study is more in line with that. This is 250 men, all had a systematic biopsy, and they additionally had a targeted biopsy. And you can see that the rates of clinically significant cancer detection were similar, but when you combine the two together, the rate was higher. And that's really what we see in our data as well. The added value of the systematic biopsy is about 5%. The added value of the targeted biopsy is about 7%. Importantly, what they didn't talk about much, but what you can ferret out in the data, is that if you do the systematic biopsy, that's really what fuels the indolent cancer detection. And in fact, you quadruple the rate of indolent cancer detection. So that's really the way to think about it. I will quadruple indolent cancer detection to pick up an additional 5% of clinically significant cancers. And the real question is that necessary? The final study is the screening population study that was done by the Swedish investigators. And this was basically a randomization of two screening strategies. One, the reference strategy, which was that all men with a PSA greater than 3 had an MRI followed by systematic biopsy plus MRI targeted samples. And then the experimental strategy, in which all men with a PSA greater than 3 had an MRI, no biopsy if they were PIRAD 1 and 2, and MRI targeted biopsy only. So basically the precision strategy is the experimental strategy. And they concluded that avoiding systematic biopsy in favor of MRI directed targeted biopsy would reduce the overdiagnosis of cancer by half, akin to what I was just saying. And this would really delay the detection of a very small proportion of intermediate risk patients. But actually, when you look at the data, I would conclude something different. So here's their data spread. What we see is that if you look at indolent cancer detection in the men who have PIRAD 3 to 5 abnormalities, between the two screening strategies, it's actually identical. It's not reduced by not doing the systematic biopsy. On the other hand, among men who were not biopsied, the PIRAD 1 and 2, that's where the risk reduction for indolent cancer occurred. 9.8% in the men who were biopsied, and of course 0 in the men who were not. And by avoiding biopsy in the PIRAD 1, 2, you gave up 2.2% of the significant cancers. So I think the real risk reduction occurs by not biopsying people who are low suspicion and don't need it. And we've developed, a number of strategies. I don't have it in this talk, but we've developed a number of strategies to say, how do we further risk stratify that low risk group? One thing we did do was go back and say, what are we missing? So we applied the precision data set criteria to our biopsy data set, and we looked at what exactly are we missing. These are the cancers we miss by avoiding PIRAD 1 and 2. And what you see is that on rare occasions, there are patients who have Gleason 4/5 PIRAD greater than 10. This data is a little skewed in that we don't biopsy every PIRAD 1/2, so our PIRAD 1/2 might be a little higher risk population. But the majority are low-grade small cancers, lower grade with minimal pattern 4, and most of them actually meet, CAPRA low risk criteria or Epstein low risk criteria. So we think what we call clinically significant may not always be clinically significant. So this is sort of the yin yang. This is where our early data brought us. It brought us basically to the idea that if you increase sampling, if you biopsy everybody, you will find slightly more clinically significant cancer, but you will greatly escalate indolent cancer detection. If you decrease sampling, you're going to miss a few, but you'll greatly reduce the indolent cancer. And that's where urologists, I think, have to try and figure out their balance. So I'm going to try to get through some of this in fast so that we can have time for discussion. What does tumor detection mean on MRI? Remember, that was our original question. And there's now growing evidence that not only is it morphologically different, but that there are genetic signatures of aggressiveness. We see different genomic patterns. We see different immunoregulatory patterns in these cancers. There's growing evidence of increased biologic aggressiveness at the genetic level. So that's an area of great interest to us. Can we distinguish these cancers genetically in building radiogenomic signaling patterns that are predictive of outcome? What are the limitations of MRI? Well, simply, I would categorize them in three. It misses cancers, and we worry about that. It's costly. We worry a lot about that. And there's not really great access in every part of the world or every part of the United States. So with regard to the first, there are a lot of things that will influence the quality of the MRI, gas, hip hardware, movement. So when we look at that PROMISE data, you actually find a good number of the MRIs that were incorrect in PROMISE or missed cancers were in the setting of poor quality MRIs. There's interreader variability, even among experts. And of course, you may miss things with MRI-targeted biopsy, false negatives. One of the young radiologists I work with, Angela Tong, and I started a QI project to say, can we figure out why we see discordance between MRI-targeted biopsy and the study itself? So what we do every Friday, she and I meet, we go through only my cases that are discordant to try and understand why they're discordant. And this is the initial report of 472 biopsies over roughly a 1-year period where we evaluated the discordance. What we did was create a 4-stage process where we describe the nature or define the nature of the discordance, and we defined it in different ways. Somebody with a pyrad 4 that's benign, somebody with higher grade cancer in the systematic than in the target, et cetera. We then evaluate the quality of the MRI. We looked for missed lesions. We reassess the pyrad. We do a pathology review to see if there's unique pathology, inflammation, et cetera, that might predict why that was missed. And we do spatial alignment of the biopsy. We classify it as either targeting error, incorrect pyrads, or simply disease that the MRI doesn't see. And then we validate this by either repeating the biopsy, reviewing the radical prostatectomy specimen, or if we believe that everything was wrong, then we may just go straight to treatment. So examples of misclassification, this is an example of a mistargeted lesion where the patient had cancer in core 7, but the targets from core 13 were benign. So that's simple targeting error. This would be a misclassified pyrad where this was called a pyrad 2, ended up high grade, and when we did a consensus re-review, the consensus was it should have been rated a 3. And of course, there can be histologic explanation. This is a patient with a pyrad 4, and all the core samples from that area show acute inflammation. We looked at this, and among my cases, disturbingly high number of discordance, 61 out of 472. And that's in a learning curve now. I've probably done, I don't know, 6,000 or 7,000 fusion biopsies. So that's disturbing. But of course, within that, about a fifth were studies that were MRIs not done at NYU. So MRI quality may be an issue. And some of them were post-treatment studies, which we would probably exclude. When we segregate the types of discordance, what I would show you is that the most common are patients who have benign pyrad 4 or 5 or low-grade cancer in a pyrad 4-5 lesion. And when we look at the reasons, I've arrowed out 3 because I believe these are all correctable potentially with technology. That would be incorrect pyrads, targeting error on the biopsy, or a high pyrad score with benign or low-grade prostate cancer. So using technology may help us. And this is one study that shows that you can overcome interreader variability with deep learning techniques. So if we use a deep learning, system, an AI platform to help with candidate lesion localization and qualification, the PIRADS greater than 4 reading accuracy improved overall. The inter-reader concordance improved as well. So AI can definitely help radiologists probably in reading a little bit better with regard to PIRAD. What are the limitations of prostate MRI with regard to cost? Well, it's scanner time, opportunity cost, increased healthcare expenditure, and of course the access. So we've been interested in this area as well. We just participated in a global study from the Precision Group called the PRIME study, in which there's a comparison of biparametric to multiparametric. This would greatly reduce time in the scanner and cost of the study in the United States if it were to show equivalence. I think actually Viru showed some of the data at EAU, or is showing some of the data at EAU, but I'm not privy to the outcome of the study just yet. But this will be very important, because if you can get rid of the DCE, you will increase access and reduce cost. We've also been interested in looking for scanners that are lower cost with lower power requirement and decreased complexity. So one of the investigators at my place, Patricia Johnson and Hirsch Chandarana, who's a radiologist in our group, they've been looking at accelerated MRI. And the idea being that when you take imaging at any resolution, it's simply data that can be processed by AI platforms to improve the quality of the data. So on the left, you have a conventional T2. On the right, you have a 6-fold accelerated T2 that's reconstructed with an AI platform, and you can see the image resolution is pretty similar. This is sort of like what Miles has done a little bit with the SRH as well in terms of accelerating it. Here, this is a diffusion sequence. On the top is a standard 5-minute diffusion sequence. On the bottom, an accelerated diffusion sequence that's been reprocessed with AI. And when you look at the impact, the conventional multiparametric MRI takes about 30 to 45 minutes, depending on the protocol. A biparametric, you can reduce it to 15 to 20. If you do the rapid screen, it could be less than 5 minutes and save about 40 minutes of scanner time. Another area of interest is low field imaging. This would be the idea that you improve signal noise ratio and image resolution with AI post-processing of the raw imaging data. So my collaborators have been looking at an AI-enabled T2 weighted image from a low field 0.5 Tesla MRI scanner, which is cheap and fast, comfortable for patients. And so you can see here, this is still a work in progress, obviously, but these are images, initial T2 images from 0.5 Tesla. And what you can see in the middle here is post-processing, the diffusion image is actually quite good and close to a 3 Tesla image scanner at a much lower resolution. So these types of scanners could even be implanted in the urologist's office in theory. The final thing I wanted to talk about, if we have a couple minutes, because I know there's a lot of interest, as I understand it, here in Vancouver and in Canada in general with micro ultrasound. And we've only had micro ultrasound at NYU. I brought it in about 2 years ago. So we have a limited experience with micro ultrasound. But I think it's worth mentioning because clearly micro ultrasound is another way you could reduce the cost of MRI, right? So this is what is micro ultrasound? It's high frequency transrectal ultrasound, which improves tissue resolution. It operates at a higher frequency. So the standard ultrasounds that we use in the office are 6 to 12 megahertz. Generally, micro ultrasound operates at 25 to 29 microhertz and shows resolution that's very low, down to 70 microns. And you can see actually small ductal architecture within the prostate. You see on the lower right panel, you can see previous biopsy cores, scars from previous biopsy samples. And this, and I can say this is not concocted. We actually see the old biopsy tracks. Whether that helps you in following patients is an interesting question. One of the things that we observed in my group, Ben Press was a medical student who worked with me for a year, and I think he's just finished urology residency. But Ben and I did a project where at the time of the fusion, we would look to see if we see an ultrasound hypoechoic abnormality at the fusion site. Often you do see one. And it's interesting because if you do the truss without the fusion, I think most urologists don't see these subtle abnormalities. Now you overlay the MRI, and you can see on the right, as an example, two MRI abnormalities on the right and the left, and clearly there's a hypoechoic area on the ultrasound that correlates. So I started prospectively classifying all our fusions based on the presence of a hypoechoic region of interest at the site of the fusion on a 3-point scale. And what we showed was that using the ultrasound scale, it was predictive of cancer, and more importantly, it was predictive of clinically significant cancer based on Gleason score. Even when we put this into a multivariate analysis with PIRADS, it was still independently predictive. So it tells you the ultrasound characteristics may have some biologic significance as well. So these are examples of micro ultrasounds. Sangeet Ghai in Toronto has established a scale called Primus, which is the micro ultrasound version of PIRADS. And you can see the different types of tumor presentation, sort of speckled, heterogeneous architecture. But most importantly, you see in the right upper image the best. You can see this linear ductal architecture. And whenever you see that's disrupted, that's an indicator of cancer within that location. The data recently published in a meta-analysis by Lori Klotz shows that micro-ultrasound, when compared to MRI and all the early studies that have been done, is non-inferior. And in fact, it may have better sensitivity and better negative predictive value. And that Primus performs similarly in prediction to PIRAD across the board. It's interesting to note that PIRAD 1 and 2 abnormalities often those patients will end up having high Primus scores, and in a small group of patients in low Primus, there'll be high PIRAD scores. If you look in the lower right panel, you'll see that when you do both, micro-ultrasound identifies some unique cancers in gray, MRI identifies some unique cancers in yellow. This is not very different than MRI first. So you have to think, is this really about what you're seeing on the ultrasound, or is it just because you're sampling the patient more? Because we see more cancers just with random sampling on systematic biopsy. And that's well illustrated now by, I think, the best study that's been published, which is from Sangeet, which is a prospective comparison of the two techniques. And what they did in this study was that the patient had a 3T MRI, examiner 1 marked the PIRAD lesion, then examiner 2, who was blinded to the MRI, did a micro ultrasound and marked any Primus lesions. Examiner 2 was then unblinded. If in patients who had both a concordant MRI and ultrasound abnormality at a site, that lesion was sampled directly twice. Discordant lesions were additionally sampled twice, and then patients with normal MRI just got a 12-core biopsy. Important things they found in this study, in the top panel, you can see that the rate of clinically significant cancer detection was the same between micro-ultrasound targeted biopsy and MRI targeted biopsy. You can see that clinically insignificant cancer was the same as well. The bottom panel is telling you that a third of patients had a normal MRI and would have avoided a biopsy. Only 10% of the micro-ultrasound patients would have avoided a biopsy because of the number of abnormalities. And then in the bottom panel, what you see is that among the discordant lesions, the ones that were seen only on micro-ultrasound, there were 100, and 9 of those were malignant. And MRI targeted biopsy, there were 31, and 8 of those were malignant. So what you learn from this study is that they're similar with regard to overall cancer detection. More biopsies are avoided with MRI than ultrasound, more unique lesions on the ultrasound, which leads to more biopsies being taken. If you put them together, you do increase the overall rate, but overall, you're doing more biopsies to detect a similar number of cancers. And getting back to that original optimization definition, maybe it doesn't quite achieve it. There's an ongoing multi-center randomized trial that'll give us more data. So to wrap it up, MRI of the prostate, what have we really learned? Well, I think over my 12 years of doing this, we've learned a lot. I think it's changed the diagnosis, the risk assessment, treatment of prostate cancer, better biopsies, better selection, better surveillance. I didn't show you our surveillance data, but we have a paper forthcoming with our updated MRI surveillance, better surgery, new frontier in focal therapy. And I think globally, this continues to improve. I think our standards will improve. I think reader experience will improve. The emergence of PET and the addition of molecular signals may help us to better understand, what does it mean to have visible disease? MRI quality, cost remains a major concern and an obstacle to uniform adoption, but we're looking at ways to improve that. I have a donor, I learn a lot from my donors. I would call them advisors, who always asks me about new ideas. Is it evolutionary or revolutionary? So one day I went and looked that up. What exactly is the difference? And it's interesting that evolution is thought to be slow change and revolution is thought to be rapid and sudden. So the question of revolution versus evolution is very interesting, but sometimes something that evolves the needle requires a little bit of a leap of faith on the part of the practitioner, and then it can become revolutionary. And I think that's really where MRI or imaging in general is in our field. So is MRI evolution or revolution? Well, I think in risk assessment and biopsy, it's probably evolutionary. It's one more signal for us to look at. But the way we do biopsies, it is revolutionary. It's improved the biopsy paradigm. Staging, surgical planning, evolutionary. Focal therapy, hopefully, will be revolutionary in that it will offer a new paradigm for a select number of men. Where can we go further? Well, I would tell you that all of the things I showed you might show some incremental improvement. Machine learning, molecular imaging, these things will definitely improve the paradigm. But I think the real question that we still have to get at is MRI PET in visible cancer biologically relevant? Is it really clinically significant if we don't see it? And can we predict the tumor behavior using the imaging? I would argue that if I came back to you in 10 years and I'm not retired on a boat, that we will be predicting tumor behavior with imaging without biopsies. But let's see if we get to that point. Thank you.